This is pre-work in our continuing series on the changing brain. This is regarding the etiology and treatment of childhood. Childhood is a syndrome which has only recently begun to receive serious attention from clinicians. The syndrome itself, however, is not at all recent. As early as the 8th century, the Persian historian Kidnam made references to short, noisy creatures who may have been what we now call children. The treatment of children, however, was unknown until this century when the so-called child psychologists and child psychiatrists became common. Despite this history of clinical neglect, it has been estimated that well over half of all Americans alive today have experienced childhood directly, as Seuss pointed out in 1983. In fact, the actual numbers are probably much higher, since these data are based on self-reports which may be subject to social desirability biases and retrospective distortion. The growing acceptance of childhood as a distinct phenomenon is reflected in the proposed inclusion of the syndrome in the upcoming Diagnostic and Statistical Manual of Mental Disorders, 4th edition, or DSM-4 of the American Psychiatric Association. Clinicians are still in disagreement about the significant clinical features of childhood, but the proposed DSM-4 will almost certainly include the following core features. 1. Congenital onset. 2. Dwarfism. 3. Emotional lability and immaturity. 4. Knowledge deficits. 5. Legume anorexia, or in the modern lexicon, legumophobia. Clinical features of childhood. Although the focus of this talk is on the efficacy of conventional treatment of childhood, the 5 clinical markers mentioned above merit further discussion for those unfamiliar with this patient population. Congenital onset. In one of the few existing literature reviews on childhood, Temple Black in 1982 has noted that childhood is almost always present at birth, although it may go undetected for years or even remain subclinical indefinitely. This observation has led some investigators to speculate on the biological contribution to childhood. As one psychologist has put it, we may soon be in a position to distinguish organic childhood from functional childhood. Rogers in 1979. Dwarfism. This is certainly the most familiar marker of childhood. It is widely known that children are physically short relative to the population at large. Indeed, common clinical wisdom suggests that the treatment of the so-called small child, or tot, is particularly difficult. These children are known to exhibit infantile behavior and display a startling lack of insight. Tom and Jerry, 1967. Emotional lability and immaturity. This aspect of childhood is often the only basis for a clinician's diagnosis. As a result, many otherwise normal adults are misdiagnosed as children and must suffer the unnecessary social stigma of being labeled a child by professionals and friends alike. Knowledge deficits. While many children have IQs with or even above the norm, almost all will manifest knowledge deficits. Anyone who has known a real child has experienced the frustration of trying to discuss any topic that requires some general knowledge. Children seem to have little knowledge about the world they live in. Politics, art, and science. Children are largely ignorant of these. Perhaps it is because of this ignorance, but the sad fact that most children have few friends who are not, in themselves, children. Legume anorexia or legumophobia. The last identifying feature is perhaps the most unexpected. Folk wisdom is supported by empirical observation. Children will rarely eat their vegetables. See Popeye 1957 for review. Now, what can we say about the causes of childhood? Recent years have seen a flurry of theory and speculation from a number of perspectives. Some of the most. Now that we know what it is, what can we say about the causes of childhood? Recent years have seen a flurry of theory and speculation from a number of perspectives. Some of those prominent are reviewed below. The sociological model, Emil Durkheim was perhaps the first to speculate about sociological causes of childhood. He points out 2 key observations about children. 1, the vast majority of children are unemployed, and children represent one of the least educated segments of our society. In fact, it has been estimated that less than 20% of children have had more than a 4th grade education. Clearly, children are an out group. Because of their intellectual handicap, children are even denied the right to vote. From the sociologist's perspective, treatment should be aimed at helping assimilate children into mainstream society. Unfortunately, some victims are so incapacitated by their childhood, they simply are not competent to work. One promising rehabilitation program, Spanking Alfalfa in 1978, has trained victims of severe childhood to sell lemonade. The biological model, the observation that childhood is usually present from birth, has led some to speculate on a biological contribution. An early investigation by Flintstone and Jetson in 1939 indicated that childhood runs in families. Their survey of over 8,000 American families revealed that over half contained more than one child. Further investigation revealed that even most non-child family members had experienced childhood at some point. In cross-cultural studies, Mowgli and Din in 1950, indicated that family childhood is even more prevalent in the Far East. For example, in Indian and Chinese families, as many as 3 out of 4 family members may have childhood. There's an impressive evidence of genetic component of childhood comes from a large-scale twin study by Brady and Partridge. These authors studied over 106 pairs of twins, looking at concordance rates for childhood. Among identical or monozygotic twins, concordance was unusually high, 0.92, i.e. when one twin was diagnosed with childhood, the other twin was almost always a child as well. Then there's the psychological models. A considerable number of psychologically based theories of the development of childhood exist. They are too numerous to review here. Among the more familiar models are Zugman's learned childishness model. According to this model, individuals who are treated like children eventually give up and become children. As a counterpart to such theories, some experts have claimed that childhood does not really exist. Zaz has called childhood an expedient label. In seeking conformity, we handicap those whom we find unruly or too short to deal with by labeling them as children. Well, how do we go about treating childhood? Efforts to treat childhood are as old as the syndrome itself. Only in modern times, however, have human and systematic treatment protocols been applied. In part, this increased attention to the problem may be due to the sheer number of individuals suffering from childhood. Government statistics from the Department of Health and Human Services reveal that there are more children alive today than at any time in our history. To paraphrase P.T. Barnum, there's a child born every minute. The overwhelming number of children has made government intervention inevitable. The 19th century saw the institution of what remains the largest single program for the treatment of childhood, so-called public schools. Under this colossal program, individuals are placed into treatment groups based on the severity of their condition. For example, those most severely afflicted may be placed in a, quote, kindergarten, end quote, program. Patients at this level are typically short, unruly, emotionally immature, and intellectually deficient. Given this type of individual, therapy is essentially one of patient management and of helping the child master basic skills, for example, finger painting. Unfortunately, the school system has been largely ineffective. Not only is the problem a massive tax burden, but it has failed even to slow down the rising incidence of childhood. Faced with this failure and the growing epidemic of childhood, mental health professionals are devoting increasing attention to the treatment of childhood. Given a theoretical framework by Freud's trademark treatises on childhood, child psychiatrists and psychologists have claimed great successes in their clinical interventions. By the 1950s, however, the clinicians' optimism had waned. Even after years of costly analysis, many victims remained children. The following case, taken from Gumby and Polk in 1957, is typical. Billy J., age 8, was brought to treatment by his parents. Billy's affliction was painfully obvious. He stood only 4 feet 3 inches high and weighed a scant 70 pounds, despite the fact that he ate voraciously. Billy presented a variety of troubling symptoms. His voice was noticeably high for a man. He explained legumophobia or legumanorexia, and according to his parents, often refused to bathe. His intellectual functioning was also below normal. He had little general knowledge and could barely write a structured sentence. Social skills were also deficient. He often spoke inappropriately and exhibited a whining behavior. His sexual experience was non-existent. Indeed, Billy considered women icky. His parents reported that his condition had been present from birth, improving gradually after he was placed in a school at age 5. The diagnosis was primary childhood. After years of painstaking treatment, Billy improved gradually. At age 11, his height and weight had increased, his social skills are broader, and he is now functional enough to hold down a paper route. After years of this kind of frustration, startling new evidence has come to light which suggests that the prognosis in cases of childhood may not be all gloom. A critical review by Fudd in 1972 noted that studies of the childhood syndrome tend to lack careful follow-up. Acting on this information, Moe, Larry, and Curley began a large-scale longitudinal study. These investigators studied two groups. The first consisted of 34 children currently engaged in a long-term conventional treatment program. The second was a group of 42 children receiving no treatment. All subjects had been diagnosed as children at least 4 years previously, with the mean duration of childhood at 6.4 years. At the end of 1 year, the results confirmed that the clinical wisdom that childhood is a refractory disorder, virtually all symptoms persisted, and the treatment group was only slightly better off than the controls. The results, however, of a careful 10-year follow-up were startling. The investigators, Mo, Larry, Curley, and Schemp, assessed the original cohort on a variety of measures. General knowledge and emotional maturity were assessed with standard measures. Height was assessed by the metric system, and legume appetite by the Vegetable Appetite Test, or VAT, designed by Popeye. Mo et al. Found that subjects improved uniformly on all measures. Indeed, in most cases, the subject appeared to be symptom-free. Mo et al. Report a spontaneous remission rate of 95%, a finding which has certainly revolutionizes the clinical approach to childhood. These results suggest that the prognosis for victims of childhood may not be as bad as we have feared. We must not, however, become too complacent. Despite its apparently high spontaneous remission rate, childhood remains one of the most serious and rapidly growing disorders facing mental health professionals today. And beyond the psychological pain it brings, childhood has recently been linked to a number of physical disorders. 20 years ago, Howdy, Doody, and Bozo demonstrated a 6-fold increased risk of chickenpox, measles, and mumps among children compared with normal controls. Later, Barbie and Ken linked childhood to an elevated risk of accidents. Compared with normal adults, victims of childhood were much more likely to scrape their knees, lose their teeth, and fall off their bikes. Clearly, much more research is needed before we can give any real hope to the millions of victims racked by this insidious disorder.
Okay. 5, 4.
My name is Wendy Bellissimo, and I got to know Jeanette through my 4 little girls who absolutely adored her. And there's a thought that I'd like to leave everyone about Jeanette. It's one day we were by the pool, and my 4 little girls were in the pool with Jeanette, and I happened to be walking by right at the moment when Jeanette was sitting on the step with my 3-year-old. And my 3-year-old asked Jeanette, what happened to your leg? And I stopped dead in my tracks, wondering what Jeanette was going to explain to this little 3-year-old. And Jeanette looked at my daughter Marley and said, a shark bit it off in the pool. And I think that lightheartedness and just Jeanette's ability to just kind of take things lightly and not so heavily all the time is a great lesson for all of us. We all know she was an angel. She was so special and giving and kind, but also that she was able to keep things light and happy is something we should all carry with us about her every day as we grow.
Thank you very much.